is all about the management of diabetes is more than just glucose. From glucocentric to the holistic approach in type 2 diabetes management, we once again have the chairpersons Dr. Guru Prasad Bhattacharya and Dr. Mridul Bera. Over to you, sirs.
The second talk in this hall A is from glucocentric approach to holistic approach in type 2 diabetes mellitus patients. And the speaker will be no other than Dr. Sagarika Mukherjee. Sagarika Mukherjee is known to me personally for many years. She is very bright looking with bright backup of knowledge related to diabetes and medicine. I will ask Dr. Sagarika Mukherjee to start her session.
Dr. Mukherjee, are you there?
I am there very much. I'm just trying with the struggling with the technology a bit.
Okay, no problem.
Trying to share my screen.
Now the struggle is over, ma'am.
Am I visible now?
Now the struggle is over. Please share your slides. Okay, you are visible now.
Yeah, visible.
Right. I'll try and share my screen. You cannot share screen while the other participant is sharing. Okay.
Please go ahead, ma'am. Please go ahead.
Shall I try again?
Yeah. Please do now.
Right. Okay. Many thanks to the organizers for asking me to come and talk. I feel really very honored. The first time Mridul contacted me to come and talk here, I really felt honored. And I'm very grateful to Boehringer and Ingelheim for sponsoring this session. Thank you ever so much. And without delay, let's progress to the slideshow. Right. I will be talking about how you can manage diabetes in a more holistic approach, or in a way, how can you just not concentrate only on glucose control, but rather think of the patient as a whole, and how can you overall reduce the mortality and morbidity of the patient, right? Now, as we know that diabetes is basically a vascular illness. Now, from when does this vascular illness starts to develop? It starts to develop long way before your actual diagnosis of diabetes in the pre-diabetes era, when you have your insulin resistance building up, a lot of inflammation going on in the body. Now, this inflammation is also what this inflammation does is messes up with your endothelium and it gives rise to cardiovascular problems as well. So, at tandem or at par, what is going on? There is insulin resistance going on, endothelial dysfunction going on in the pre-diabetic stage, which if not arrested properly and if not managed properly, finally culminates into type 2 diabetes with a lot of metabolic problems like hyperglycemia, obesity, dyslipidemia, fatty liver disease, the whole spectrum of the metabolic problems, and also give rise to cardiovascular problems like hypertension, dyslipidemia, atherosclerosis leading on to heart failure and acute coronary syndrome. On the other hand, there are some renal dysfunction goes on as well because of hypertension and because of endothelial dysfunction. Renal problems associated with vascular disease also increases, and as a result of this, microalbuminuria starts, which goes on to frank albuminuria, and if not arrested properly, goes on to frank renal failure. The background works in this way. You have certain degrees, you have a certain genetic preponderance for doing this, as well as if you are exposed to the correct environment, then you succumb to all these things. Associated with it is our westernized lifestyle. We are more sedentary now. We tend to consume more calorigenic food. That is, we tend to consume lot of amount of refined carbohydrates, lot of amount of fat. We exercise less. Our chances of doing daily exercise, not just physical exertion, but chances of just moving around in the house is also reduced because we tend to control everything with a remote, and life has become very easy. Ordering food from outside and food preparation has also become very easy. So physical exertion has really become a bit of a challenge, which tends to really push all these metabolic problems even further ahead. As a result of this, they have a lot of metabolic abnormalities, visceral adiposity, reactive oxygen species building up in the body, inflammation going on, changes in the microbiota in the gut, and gives rise to glucotoxicity as well as lipotoxicity. Diabetes and heart disease goes hand in hand from the beginning, from the pre-diabetes era itself, because the primary concern for diabetes and heart disease, it stems from something, a common soil, that is, there is some oxidative stresses going on associated with inflammation and outpouring of inflammatory molecules like IL-6, VEGF, PI1, etc., along with cellular apoptosis, which gives rise to changes in your myocardium, which finally culminates into heart failure and acute coronary syndrome, as well as there are some renal abnormalities as well going on with loss of nephrons, microalbuminuria, giving rise to hypertension, which again is related to heart disease. So diabetes really, when it starts building up, it really affects your heart and your kidneys side by side. So when you're treating your diabetic patient already who has presented to you with a problem of diabetes, then you're going to think about, am I going to just control the blood sugar? Is that going to be enough? Or am I going to really address his heart, his kidney, his other metabolic problems, so that we are really preventing long-term complications of diabetes and giving him a better life with diabetes? So we need some early intervention in order to prevent complication, and also at the same time you have to be very mindful about weight loss, which is also weight loss because most of our type 2 diabetic patients are also obese. So you want profile of the clinically diagnosed type 2 diabetes among the Asian Indians. At that point of diagnosis, the HbA1c is really about 9.1%, and at the time of screening it's about 8.3%, and this has stemmed from the ICMR study in the 2020, which is quite a grim picture. And when you think about the goal of treatment of diabetes, as our textbook had taught us, that you start with diet and lifestyle, you start with one medicine, then progress on to other medicine, you wait for about 3 to 6 months before you progress on to another medicine. So which means it taught us about the clinical inertia, where we lingered on for a prolonged period of time, and as a result of this, because of the physician's clinical inertia, the patient is left in a hyperglycemic state in a prolonged period of time, and this hyperglycemic state worsens the inflammation inside the body and therefore worsens your cardiovascular problem as well as problems associated with glucotoxicity. So rather than following one medicine after the other, why don't we address the patient as a whole and address each of the pathophysiological problems together? Because we know that with 1% reduction of HbA1c, which was taught by UCOPDA study, non-fatal MI or fatal MI reduces by 14%, heart failure by 16%, deaths from diabetes by 21%, microvascular complication with 37%, and amputation, which is still one of the commonest causes of amputation, is diabetes, is reduced, and vascular disorders reduced by 43%. Now, efficacy of the modern diabetic treatment, that is DPP-4 inhibitor, SGLT2 inhibitor, GLP-1 receptor agonist, gives a little bit of positive edge with the Indian subcontinent patients, because in all of the large meta-analysis study, or in all of the large studies with all these modern medicines which are shown in a meta-analysis, that Asians actually fared much better than the whites, and therefore these medicines tend to work a little bit in a better way. So coming away from the diabetes physiology, that we used to think that it is all centered around glucose, that is where pancreas was defecting, and also there is insulin secretion was defective, and hepatic glucose output was increased and peripheral glucose uptake was reduced. This was the glycemic triad. We have now moved into glycemic into hyperglycemia octet, or even there are lot of more pathophysiology. So rather than centering only on the glucose, if we address each and every aspect of this pathophysiological octet, then we are really treating the patient in a much better way. Because if you give a combination of SGLT2 inhibitor and DPP-4 inhibitor, if you're mindful that they touch upon each of the important points of the ominous octet, DPP-4 inhibitor takes care of most of the points in the octet, whereas SGLT2 inhibitor complements it by taking care of the renal mode of action, and therefore you are holistically approaching the patient, addressing not only the toxicity but also reducing their complication and increasing their longevity in the long run. So how does it affect the beta cell function? Or in a way, how do you know that if your beta cell function is working or not? Now, measuring beta cell function is a research tool. It is not available for clinical practice. But nevertheless, we need to have something like a basic understanding of beta cell function. Usually, beta cell function is measured through a HOMA model, that is homeostasis model for assessment. And with the HOMA model, if you measure with HOMA B, it measures your mainly fasting insulin concentration versus fasting glucose concentration, which gives you an idea of the beta cell function. There is another thing called HOMA insulin resistance, which measures your fasting insulin concentration to glucose concentration, but gives you an idea about how much of insulin resistance you have. So if you have HOMA IR is much higher than HOMA B, then definitely your insulin resistance is higher, which is deleterious. So you have to choose your medicine in such a way so that which brings down your HOMA IR as well as increases your HOMA B. Increasing HOMA B means you're rejuvenating your beta cell, you're preventing the beta cell apoptosis, you're promoting the beta cell to produce its own insulin more and more. So what we have seen with empagliflozin and linagliptin, that in both of these medication reduces your HOMA IR when compared with placebo, as well as increases your HOMA B function, which in a term it means that improves your pancreatic beta cell function, improves its pancreatic beta cell secretory capacity, and prevents the apoptosis of beta cells in the long run. So when you give a fixed dose combination of EMPA and LINA, what it does is that it not only lowers your baseline HbA1c, obviously you can see that the robust reduction of baseline HbA1c is seen at the higher dose of EMPA with 25 milligrams. If you start with a very high HbA1c, say for example 9%, 9.5%, then you see a better reduction of HbA1c than if you start at a lower percentage of HbA1c. Not only that, it has been proven in long-term studies that it provides you a certain degree of protection from your renal impairment, as well as the cardiovascular benefit is already there, and all this is really this is provided at the cost of minimum risk of hypoglycemia. So weight reduction is again an additional benefit with these agents, because along with loss of glucose, there is some loss of calorie loss as well with empagliflozin, and it reduces weight, which is again a greater advantage for type 2 diabetic patient. Because with calorie loss and loss of glucose, there is some loss of fluid as well. This affects your systolic blood pressure, and as a result, the systolic blood pressure comes down. When your systolic blood pressure comes down, the arterial tone improves, the sympathetic tone of the artery improves, therefore the afterload on the heart improves, and therefore this gives you an additional benefit for the heart. And there is also some reduction of serum uric acid level. Uric acid again is a point in the metabolic spectrum. So when your entire metabolic situation improves, there is bound to be reduction of your uric acid level, which indicates that your entire metabolism is improving and your insulin resistance is coming down. All this is offered at the risk of low hypoglycemia, because SGLT2 inhibitor works without the pancreas, and DPP4 inhibitor, that is linagliptin, works with the pancreas but is dependent on the amount of carbohydrate which is ingested in the meal. So they do not work. If the carbohydrate amount is less, it doesn't secrete the increased amount of insulin, and this makes it cause less amount of hypoglycemia with increased efficacy. And also what we have seen is SGLT2 inhibitor, one of the stumbling block is genitourinary tract infection, especially for obese patients and very uncontrolled diabetes. But when SGLT2 inhibitor are combined with DPP4 inhibitor, it has been seen that genitourinary tract infection is far less. The reason behind this is that most of the time genitourinary infection is caused by fungus, and the fungus contains certain DPP4 receptors which is inhibited by linagliptin, and therefore the growth is a bit stunted, and you have lesser amount of genitourinary tract infection. The Empiric outcome study has already shown us that cardiovascular death is reduced by 38%, heart failure reduced by 35%, and 3-point MACE by 14%, any cause of death by 32%, nephropathy progression reduced by 40%, and renal composite endpoint, that renal composite endpoint means progression of microalbuminuria to macroalbuminuria, progression, doubling time of creatinine, progression to end-stage renal disease is reduced by nearly half, 46%. So these medicines really work when you study the total analysis of Empiric outcome studies, and you see that these medicines work within a very short period of time after starting the medicines on the patient. So therefore, you see that there is a reduction in cardiovascular death which was not seen with the other SGLT2 inhibitor in the cardiovascular outcome studies. And the DPP4 inhibitor study with CV and renal outcome already has shown that Carmelina stands out amongst all the other DPP4 inhibitors in a way that it has got with slightly better numbers in reduction of heart hospitalization for heart failure, 3-point MACE, and also renal outcome studies. So Carmelina also had one of those studies which included highest proportion of patients with renal impairment when compared with other cardiovascular outcome studies, because TCOS, which was with sitagliptin, had only 22%. Examined study with allogliptin, of course allogliptin we do not have here, has 29%. Sevatimi with saxagliptin, only 15% had renal impairment, whereas Carmelina study was more like a real life study, was more realistic, which can be mirrored into your own clinical practice. It had about 62% of renally impaired patient. And the albuminuria progression was definitely there was a robust reduction of albuminuria progression in the Carmelina study, as you can see in this graph. So EASD and ADA consensus guidelines has already decided that when you are really starting to treat patients for type 2 diabetes, start with diet and lifestyle. Definitely that goes needless to say, and start with metformin. But then you have to really think about your model of treatment. You have to think about whether the patient has got heart problems or not, whether the patient has got renal impairment or not, and accordingly formulate your prescription so that you are giving a holistic approach to the patient. You're addressing all the pathophysiological need of the patient without giving side effects of the medicines. And also you have to say that the medicine regime becomes very complicated, so you have to choose something which will make the patient to be compliant or make the patient to be adherent to the treatment, and in that way when you select a medication which is once a day, this serves its purpose very well. So giving a fixed dose combination of EMPA and LINA can improve your medicine adherence because you're taking just one pill of the day. It's addressing all your pathophysiological points in the ominous octet, and also providing your long-term cardiovascular as well as renal protection, which is the main cause of mortality of type 2 diabetic patient. So it's recommended for patients with type 2 diabetes patient with cardiovascular disease at risk or without risk of heart failure, which has been already endorsed in the guidelines because it reduces your overall cardiovascular events and mortality, and for the risks of heart failure. So there is renal evidence. Empiric's outcome shows that 39% risk reduction of the incidence or worsening of nephropathy in type 2 diabetes patient. And also the Carmelina study has shown with linagliptin that 14% risk reduction of progression of albuminuria. And there is also some hepatic evidence that no dose modification is required, especially with EMPA as well as LINA, because they do not affect your liver metabolism. So patients with type 2 diabetes with fatty liver disease, empagliflozin significantly reduces liver fat and improves liver enzymes as well. What about the cost of treatment? Because EMPA-LINA combination is a costly combination. But when you think about the cost of diabetes treatment-wise, treating with the complication, hospitalization, monitoring, and other costs, especially when the patient is developing complication, these are the direct medical costs. And indirect costs like unemployment, loss of job, or being unpaid for days when you are sick, it really builds up to quite a lot. So when you think about giving the patient an expensive medicine, but actually you're saving it long term, it's like putting your money in a life insurance, that you're putting your premium now, but you're actually gaining or reaping the benefits much years later on. So randomized control trial with evidence of EMPA, with evidence of SGLT2 inhibitor and DPP4 inhibitor, fixed dose combination which exists in India. EMPA and LINA, which we have evidence from Empiric and Carmelina study, it reduces all of your heart problems, hepatic problems, renal problems, and you have it at once a day dose. DAPA and SAXA. DAPA is excellent molecule, but SAXA we really think about especially when we think about heart failure, because still there is some warning that it can increase your risks of heart failure. And about renal evidence, there is some limited data about saxagliptin in renal impairment. Also, it is once a day dose. Remo and Vilda, although their combination is available nowadays, but there is no CVOT outcome trial, but these are usually given twice a day dose. So benefits of EMPA and LINA combination, it provides you a metabolic benefit, that it reduces your 1.8% reduction of HbA1c. By reducing your HbA1c, it reduces your insulin resistance. When your insulin resistance comes down, then your liver fat or the fatty liver disease also improves, liver enzyme tends to improve. From cardiovascular perspective, there is significant reduction of 3-point MACE, cardiovascular death, hospitalization from heart failure, and all causes of mortality. In a way, your cardiovascular health is protected. And from renal perspective, it prevents the progression of renal impairment and reduces death from renal disease as well as end-stage renal failure. So when you're giving a combination of SGLT2 inhibitor and DPP4 inhibitor for management of diabetes, you're not only thinking about the glucose, but you're thinking the patient as a whole, or providing a holistic approach for diabetes. And also, if you think about the pill size is very small, it's supposed to be taken once a day and mainly what I tend to give is in order to maintain compliance, ask the patient to take the pill just immediately after breakfast. So therefore your adherence is also preserved. You are giving two robust molecules in just one pill, and there is the potential benefits of reduction of genitourinary tract infection, significant weight loss, reduction of blood pressure, and therefore you are achieving your glycemic targets sooner, and you are helping the patient to maintain their compliance and maintain their overall cardiovascular health and renal status. Thank you very much for listening.
Thank you, Dr. Mukherjee, for your excellent presentation. If there is any question, you can put the question in the chat box.
Ma'am, I have a question for you. I personally practice the prescribing SGLT2 inhibitor and DPP4 inhibitor pill to take after the morning tea, and to take extra 1 glass of water along with that. What is the advantage of giving it after breakfast? Because many of our patients just forgets to take breakfast. They take breakfast at 10 a.m., 11 a.m. like that.
The reason why I don't give it, because after morning tea, usually they are in empty stomach, they don't have much food, and then if the breakfast is more delayed, and if you have a potential molecule like empagliflozin, they might feel a bit woozy, might feel a bit dizzy. So in order to avoid all these things, I ask them to take most of their medication just immediately after breakfast, and then if there are any evening medicine, to take it immediately after dinner. I do not give medicine on my prescription in between, just to improve compliance. And the thing that you're advising to take 1 extra glass of water is excellent, especially in the summer months. People who are on SGLT2 inhibitor, ask them to take about 400 to 500 ml extra water just to compensate for the fluid loss that is happening.
Excuse me.
Okay.
The linagliptin is a parenteral. Linagliptin is a parenteral, whereas empagliflozin is oral. How can you combine?
Linagliptin is
Linagliptin is not parenteral, sir. Linagliptin is also an oral preparation.
Okay, thank you.
GLP-1 receptor agonists are injections like dulaglutide, liraglutide. These are injections and subcutaneous injections. Linagliptin being a DPP4 inhibitor, this is an oral medicine.
Okay.
Okay, I have a question, just one last question to Dr. Mukherjee. Now, if you have to choose the combination of the dapagliflozin and linagliptin, and the combination of the empagliflozin and linagliptin, which one you will choose? Because if you see the dapagliflozin, we have the whole total population that is, because in the DECLARE TIMI we have the primary prevention trial, because all the most common patient that has been included in the DECLARE TIMI, and that means the result has been also been excellent. And if you see the DAPA heart failure, again the same thing. The heart failure benefit has been more in the DAPA heart failure study compared to the Empiric reduced trial. And the recent in the ESC, what has been discussed about the DAPA heart failure study, because the sudden cardiac death that has been dapagliflozin excellently, that is 21% reduction of sudden cardiac death. So, do you feel that the dapagliflozin probably is more superior than the empagliflozin in terms of efficacy, in terms of side effect, in terms of benefits? What do you think?
Right. When you think, first let's come to your second question first. In terms of efficacy, there is no head-to-head comparison between the 3 major SGLT2 inhibitors, that is DAPA, EMPA and CANA, to say that one is more efficacious than the other. More or less, they reduce your HbA1c to the tune of 0.8 to at best 1.1%, nothing beyond this. So efficacy-wise, they are at par. Side effect profile wise, they are also at par in terms of genitourinary tract infection, UTI or other infections. Maybe CANA has a little bit lower edge because of the amputation risk, but again the amputation thing has gone now with proven evidence. So that's side effect. When you consider about DAPA heart failure study and the ongoing studies with DAPA, the population which was chosen for the DAPA trial, they were more of a primary prevention. The population chosen for EMPA trial were more of a secondary prevention. They already had existing heart disease and they were more sick, had long-standing diabetes, whereas in the DAPA trial, the patient had newly diagnosed diabetes, they were not unwell, a large proportion of the patient had no diagnosed heart disease as well. So DAPA had improved on there. So when you're picking your patient, if your patient already has got proven heart disease, go for EMPA because the evidence is there. If your patient doesn't have any heart disease at all, but you're using it for primary prevention, go for DAPA.
Okay. Thank you, ma'am, for your excellent answer. And I will just end up the session if there is any questions. Okay, I'll end the session. Over to the next session.
Thank you so much. Thank you very much for the invitation.
Before we end the session, sir, I think we have to show who sponsored the session. So I'll
this
just
session is sponsored by BI.